learn about the modes of the ventilator. Hello everyone, myself Dr. Rachna, intensivist. I'm working in the ICU. So there are the two modes of ventilator. One is the non-invasive mode, other is the invasive mode of ventilator. So non-invasive mode we use in the spontaneously breathing patient, whereas the invasive modes we use the patient when is the patient is the intubated. So first we'll talk about the volume control ventilation. So volume control name suggests it means volume will be the controlled by us set by the ventilator. So preset tidal volume will be fixed deliver in each breath. So tidal volume will be guaranteed here and the pressure will be varying. So varying pressure will depends on the compliance of the lung, resistance of the lung, patient's effort. Here the trigger will be the patient trigger or will be the time trigger. And cycle will be the volume cycle. And how will be the wavefall will be the square constant waveform and rising pressure. Next, we'll see the advantage of the volume control. So, tidal volume or minute ventilation will be the guaranteed. What will be the disadvantage? The high peak airway pressure can cause the barotrauma and the patient ventilator asynchrony may happen. So, what will be the setting for the volume control? We can set the tidal volume that will be the 6 to 8 ml per kg according to ideal body weight. And in ARDS patient, we have to set little lower tidal volume that will be the 4 to 6 ml per kg. Then we will set the respiratory rate, we'll set the PEEP and FiO2. FiO2 we decide according to the SpO2 how much we want. Next we set the flow rate. The flow rate we set is the 1 liter per kg per minute. Then next we'll talk about the pressure control ventilation. So as the name suggests, pressure control means the pressure will be the fixed. So in fixed time, set the inspiratory pressure and pressure will be the fixed. So the tidal volume will be the varies and that will depends on the compliance of the lung and resistance of the lung. So what about the trigger? So here also it will be the patient trigger or will be the time trigger. Cycle here it's time cycle. And how will be the waveform in the pressure control? It will be the decelerating flow and square wave pattern, square pressure. So what will be the advantage of the pressure control ventilation? Lower the peak airway pressure, we can keep it here. So better the patient comfort will be there. Then this is the preferred mode in the ARDS and severe hypoxemia. So what will be the disadvantage of the pressure control ventilation? There will be the no guaranteed tidal volume here. So risk of the hypoventilation might be there at some time. Important setting, rest will be the same like FiO2, respiratory rate, everything will be same here. So TI we can set and TI will say about the oxygenation. So according to TI, our oxygenation will be affected. Next, I will be talking about the SIMV mode. That is the synchronized intermittent mandatory ventilation. So this is roughly obsolete now, but just to know. So here what we do is a fixed number of mandatory breaths will be there. So patient can breathe spontaneous between the breaths. So we will be fixing the few mandatory breaths and few will be the spontaneous breaths. So the mandatory breaths will be the fully supported by the pressure support and spontaneous breath will be the unsupported and the will depends on the patient's compliance. So what is the advantage? So this encourages the spontaneous breathing. For what will be the disadvantage? It increase the work of breathing, but this is not ideal for the weaning mode of ventilator and this is the older concept. Next, I will be talking about the pressure support ventilation. So PSV. Here is the pressure support is also known as the spontaneous mode of ventilation. So here the patient triggers all the breaths, ventilator at the preset pressure support. So here the trigger will be the patient trigger only and cycle will be the flow cycle. So whenever the flow falls, the next cycle will start. So advantage is this is the better for the patient comfort and we sometimes we use for the weaning and spontaneous breathing trial. Disadvantage in the pressure support ventilation. So there is no backup ventilation and not for the apneic patient. So how we set, what will be the setting here? So CPAP we set here is the 5 to 15 centimeter water. So pressure support ventilation, there will be the two settings. One will be the CPAP, other will be the BiPAP. So first I'll talk about the CPAP. So CPAP delivers a single continuous pressure throughout inspiration and expiration. So only one pressure will be there during the inspiration and expiration. Patient breathes spontaneously. So we said the starting pressure CPAP is 5 to 8 centimeter of water. When FiO2 we adjust according to keeping the SpO2 more than 92%. In COPD patients we keep around 88 to 92%. So we can increase CPAP gradually if hypoxemia is persistent. So we can go up to the pressure support if hypoxemia is there. So what is the common indication for the CPAP? Whenever patient has the cardiogenic pulmonary edema, obstructive sleep apnea, or mild hypoxemic respiratory failure, or we have extubated the patient but he is desaturating. So post extubation we can support with the CPAP settings. So what is the BiPAP? Now coming on to, so BiPAP, as the name suggests, bi-level positive airway pressure. So we set the two pressure. One will be the IPAP, other will be the EPAP. IPAP will be the inspiratory positive airway pressure and expiratory positive airway pressure. So patient can breathe. The benefit of BiPAP is the patient can breathe spontaneously at the both level. So how we set the BiPAP? So we start the setting with the IPAP and EPAP. IPAP is set as 10 to 12 centimeter of water, where we set the EPAP is a 4 to 5 centimeter of water. So increase IPAP if CO2 is high, and we can increase the EPAP if oxygenation is poor. So what will be the common indication? Common indication will be the COPD, exacerbation, hypercapnia, type 2 respiratory failure, obesity, hyperventilation, and neuromuscular weakness.